All the
Yeah,
students,
just
this is going to be
hold
a
on.
mock exam session. Please be interactive. You can also write in the chat box or can unmute your mic. So we'll be starting. The topic for today is respiratory medicine CCS session. And the faculty that we have here is Dr. Asif Iqbal sir. He is a HOD Respiratory Critical Care and ECMO Services at Apollo Multispeciality Hospital, Kolkata. Thank you, everyone.
So, student, this is a CCS session for the respiratory medicine. Usually, in the respiratory medicine, the commonest topic for EDIC Part 2, they will start with the community acquired pneumonia, and they will go on either if it is a long case, then they will give you the 5 variant, and if it is a short case, they might give 2 or 3 variant. So it is just a example of the cases. Like you will get first variant where actually they will not say the first one is the variant. They will, this is that it is a scenario. So you will get the scenario and you will get time approximately 10 minutes where this will not be like a short presentation. Short presentation. So they will give the details of the patient scenario and the investigation report and all. And from that point, you have to note down the problem. And when the exam will start, you have to prompt your answer. Remember, there is a no negative marks, but there might be a multiple answer. So don't say only one answer. You give maximum answer which is so there is a then there will be a chance of increase getting increased number or increased scoring. So this is a 65-year-old male admitted with a altered sensorium, complaining cough, fever for last 2 days and respiratory distress. On examination, pulse is 112, respiratory rate 32, BP 90/60, SpO2 89 in the room temperature, ABG showing mild acidosis and low PO2. Just one call. অঞ্জনদা কি কোড দিয়েছে? ট্যুরিস্ট ভিসাতে এত তাড়াতাড়ি ট্যুরিস্ট ভিসা দিচ্ছে না, ঠিক আছে? ওরা হচ্ছে যে ট্যুরিস্ট ভিসা হচ্ছে যে আজকে ইয়ে ছিল, হ্যাঁ 7 দিনে চলে এলো, 15 তারিখের আগে হচ্ছে অ্যাপয়েন্টমেন্ট দিচ্ছে না ট্যুরিস্ট ভিসার। 9 তারিখ অ্যাপয়েন্টমেন্ট চেয়েছিলাম, দেয়নি ওরা। ওরা 15 তারিখে অ্যাপয়েন্টমেন্ট দিচ্ছে, 15 তারিখে অ্যাপয়েন্টমেন্ট দিলে আমার আর যাওয়া হবে না। সেই জন্য আমি বিজনেস ভিসা অ্যাপ্লাই করছি। বিজনেস ভিসা হলে হচ্ছে যে আমি একটা পেয়ে যাওয়ার চান্স আছে। কালকে আমার অ্যাপয়েন্টমেন্ট আছে বিজনেস ভিসা। দেখো যদি সকালবেলা হচ্ছে যে কোডটা দিতে পারো, আমি তাহলে হচ্ছে ইনভিটেশন লেটারটাকে হচ্ছে যে ড্রাফট করাতে পারবো। ঠিক আছে, ওকে, ঠিক আছে। আমি একটা ক্লাসের মধ্যে আছি, আমি তোমাকে পরে ফোন করছি, ঠিক আছে? On examination, this is the AVG. Now, when this type of scenario you will get, so probably you will get this type of question: what is the case? So I will request someone, please. Can you please volunteer and Sana?
Yes, sir.
So anyone who will do volunteer from here, so he or she only can prompt this answer. If you have
Anyone
problem,
can unmute their mic, please.
so anyone, we will continue till the end. So Priyanka, you want to continue?
Yeah, yes, sir. Yes, sure, sir.
Okay. So till end, Priyanka will be with me, and okay. So Priyanka, when this case, when the examiner will ask what is your case, so that means they want to get the summary of the scenario, what you have, we have, they have given. So they want to know the positive point and the important negative point, if any negative point is there, to establish your diagnosis. So it is very clear cut cases. Sorry, it is mistake 35. It is a 65 years old altered sensorium patient with a history of cough, fever, and the respiratory distress, and there is a your hypoxia, and the respiratory distress is there. So you please summarize your case.
So this is a middle-aged male patient with the altered sensorium and features suggestive of lower respiratory tract infection. Patient is little bit tachycardic and hypotensive, and tachypneic also, and the patient is having hypoxemia, mild hypoxemia on room air. So this looks like a case of community-acquired pneumonia.
Yeah. So next question will be, what is your differential diagnosis or provisional diagnosis? So yes, you tell one diagnosis you have already mentioned, that it may be case of community acquired pneumonia. So what will be your differential diagnosis over here?
It could be aspiration pneumonitis. It could be pulmonary edema, pulmonary embolism. It could be the etiology could be varied, like bacterial, viral, fungal infection, or it could be tubercular also. Uh,
Very
and
good. So as much as you can give clue on the, so it is a pneumonia, obviously community acquired pneumonia, but you will utter that aspiration pneumonia. You will utter that it can be bacterial, viral, and fungal pneumonia. Tuberculosis, obviously you will utter, and also you will utter some like pulmonary edema, maybe other causes. Okay. So next, your provisional diagnosis obviously is community acquired pneumonia is the first your provisional diagnosis. And how will you approach this case? Next will be, how will you approach this case?
So I would like to take a basic history and do a relevant examination about the type of dyspnea, onset and duration, any risk factors if at all present, age, COPD, any alcoholism, occupational exposure in this
Uh,
patient.
here I'm giving some clue that they want to know the exactly whatever written in their answer sheet. Okay. So how will you approach this case means, they are suppose thinking that you are in the emergency and this patient come to you. So what will be your approach? Here, first you will say that I will take care of airway, breathing, circulation first. So I will check the airway whether, because it is an altered sensorium patient, whether airway is patent or not, breathing is adequate or not, and the circulation, blood pressure and vitals. Already patient is hypotensive, so I will take care of the blood pressure. I will do resuscitation, and respiratory rate is high, saturation is low, so I will give oxygen. So, and at the side, I will do other management. I will thinking about the investigation, what I will send, and I will thinking the other causes to establish my diagnosis. Like that, you will approach. They they want to know very specific answer. for per question, there may be 3 or 4 answers they have. So unless you are uttering these things, so they will not give you mark. And whatever the scenario you will get when they will say the what will be your approach, always start with ABCD, airway, breathing, circulation. They want to know these things. Okay.
So
Then,
first, I will
yeah.
manage the airway. I will ensure a patent airway in this patient, and as the patient is an altered sensorium, I will like to secure the airway. And if required, if GCS is below 8, I would like to intubate this patient. Then I will also ensure breathing, adequate ventilation in this patient, and I would like to maintain saturation above 92 to 94%. So I will connect an oxygen mask to this patient. And about circulation, I would secure IV cannula and I will give fluids, uh, 10 to
Okay.
20 per kg in
So,
this.
so next question is actually the what are the positive organism and what are the community acquired actually what are the organism causing community acquired pneumonia? So these two are the same questions. So what are the organism causing community acquired pneumonia?
Streptococcus pneumoniae is the most common causative organism of community-acquired pneumonia, followed by Haemophilus influenzae and Moraxella catarrhalis. And there's also Staph aureus causing community-acquired pneumonia, and also atypical organisms like Chlamydia legionella and Mycoplasma pneumoniae could also be there. So these are the bacterial causes. We can nowadays there is also an increased surge of viral pathogens causing community-acquired pneumonia, which could be respiratory syncytial virus, adenovirus, and rhinoviruses.
Very good. So first, obviously, you are going correct way. The community, which is the common community acquired pneumonia, streptopneumonia is the major shareholder. Then other bacteria, then atypical bacteria. Then also you go to fungal, virals, and also fungal. Because the aged patient with a, if the history of the COPD, there is a chance of aspergillus, or post-TB patient might have chance for the aspergillus. So you also include the fungal, and also you include there may be chance of the resistant organism like Klebsiella, Pseudomonas, or your MRSA. Not MRSA is not common in our part of the country, but you are appearing exam on the European country where MRSA also confirm. If they have the stem of the MRSA related question, they will ask you in same setting or in the letter on the opinion. So next, what investigation you will do?
So I would like to order a few general investigations like complete blood count, renal function test, liver function test, serum procalcitonin in this patient, chest X-ray, 12-lead ECG, ABG, and a few specific investigations like tracheal cultures, sending blood and tracheal cultures, deep tracheal aspirate also. And I would like to do a POCUS, lung ultrasound, and 2D echo.
And
2D echoes are same which
yeah.
we do in the ICU.
So, rightly mention everything, but you in European exam they are more specifics about the investigation. So you have uttered chest X-ray, yes. You
How about
also
CT
do the
chest?
AVG, and there is a blood count is already you have mentioned the blood regarding the blood count. And then you can do already chest X-ray is there. So if you can do the CT also, the CT scan, or and second thing is that what you have missed, that urinary antigen, the urinary Legionella and pneumococcal antigen. Please mention in all community acquired pneumonia cases. They want to hear these things. Okay. So that's there. Now, how will you classify from the severity of the cases, and so how will you tell the prognosis of the patient in patient family, or how will you classify the severity in community acquired pneumonia? What are the parameter you will check?
There are several indices for measuring the severity of community-acquired pneumonia, like CUB 65 score, BAP 65 score. There is a pneumonia severity index. Also, there's ATS, IDSA 2017 classification of pneumonia. But in clinical practice, we are using CUB 65 score to basically classify the severity of the disease. C stands for confusion, altered, that is altered mental status with GCS less than 8, urea more than 20 milligram per deciliter, respiratory rate above 30, blood pressure systolic below 90 and diastolic below 60, and age more than 65. Each of the parameters is given score of 1, and 0 to 1 is mild, 2 is moderate, and more than 3 is severe. So severe pneumonia actually needs ICU admission, and
Okay.
the
So
prognosis.
what is your patient's CUB 65 score?
So this is altered mental status, confusion 1 point, urea we are not having, and tachypnic patient is respiratory rate is above 30, and
So
hypotensive also. So it is
yeah,
3.
it may be
And
3 or
age
3
is
plus.
also, yeah, 4. So this is
Oh,
severe only, sir.
severe condition. Now you tell me the when there is a severe community acquired pneumonia, what will be your antibiotic management strategy?
So I would like to start with a BL-BLI combination, which is piperacillin-tazobactam combination, and if
So
the patient, I would look for features suggestive of MDR, MRSA, and other organisms. If any of them are present, then I will
first
like.
you go one by one. First you go by the your IDSA guideline. Okay. So you whatever the antibiotic related question, try to mention the IDSA guideline about this disease, because this is a European exam. If it is an Indian exam, you can utter the name of Lung India guideline, but no need to utter this Lung India guideline there. So you tell about the IDSA guideline. So it is your severe community acquired pneumonia. So IDSA guideline says if it is a community acquired pneumonia and score is lower side, like mild, moderate, severe. So in mild, you can go for the oral, only BLBLI. If moderate, you can go for the BLBLI along with the macrolide and or respiratory fluoroquinolone. And if it is a severe, then you have to give the IV, intravenous BLBLI with macrolide or respiratory fluoroquinolones. And you can utter that in India, the respiratory fluoroquinolone is restricted because our in India is TB is with epidemic. Now, there is a specific guideline for severe community acquired pneumonia. Severe community acquired pneumonia, if you are suspecting the pseudomonas, then your choice will be anti-pseudomonal drugs like piperacillin tazobactam or meropenem. Okay, along with your macrolides. If the patient having sensitivity with the BLBLI, then or allergy with the BLBLI, then you can use the this aztreonam and respiratory fluoroquinolones. And if there is a no allergy, you can go for the either piperacillin tazobactam or meropenem along with the your uh, macrolides. Then, if there is no beta-lactam allergy, severe non-pseudomonal, you are not suspecting any pseudomonal drugs, then you can go for the again the BLVLI, second or third generation cephalosporin, along with the respiratory quinolone, or you can use the azithromycin or clarithromycin. Clarithromycin is very preferable drug for the Western country. So, so you have to know about the side effect of the clarithromycin. Then they might ask about the what is the role of your steroid in the community acquired pneumonia. So, is there any role of steroid therapy?
Yes, sir. Steroids are indicated in severe community-acquired pneumonia. And there was a CAPE COD trial according to which dexamethasone 10 milligram once a day for 5 days could be given in community-acquired pneumonia, and it's known to improve oxygenation and reduce ventilator the days spent on ventilation and ICU length of stay.
Yeah. So, one more thing you also add here that the steroid is only contraindicated in case of influenza. Otherwise, steroid is indicated in a limited setting with the severe community acquired pneumonia, and it is also recommended for the COVID-related community acquired pneumonia. So though COVID is over, but during your what are the differential diagnosis or organism, you can utter COVID also here. Okay. So what are the complication of the community acquired pneumonia?
So there could be non-resolving pneumonia, there could be lung abscess or empyema. The patient can have empyema. It could be MDR, multi-drug resistant pneumonia, or it could be atypical causative organism.
So here they can be changed the variant, like this patient is not responding, patient deteriorating. So what will we do when the oxygen requirement has increased, patient having high fever? So what will be your differential diagnosis? That time you can utter that my patient may develop the complication related to community acquired pneumonia. So then they will ask you what are the complication. Then one is the empyema thoracic, lung abscess, and also the endocarditis. And there may be it can goes to the ARDS. Okay. And what will be your duration of therapy?
Sir, there were trials comparing 8 days duration with 14 days, and it was found that the 8 days is similar to 14 days in terms of the length of stay and mortality. So it is concluded that we can give safely 7 to 10 days of antibiotic therapy in community-acquired pneumonia. They the long.
Sana, you will stop the mute all others candidate. Only you keep open of Priyanka's mic. Yes, continue.
The 14 days therapy, the longer duration could be chosen in slow responders and or immunocompromised patients. For all other patients, we can continue with 7 to 10 days of duration of antibiotic.
Good. So and the they might ask you about the how will you understand that response of therapy? What are your clinical parameters?
Improvement in PF ratio
Yes.
and X-ray.
Oxygen requirement, radiological clearance, but radiological clearance needs 6 weeks. So clinically, patient oxygen requirement decrease, the hemodynamically improve, fever subside. These are the clinical response, and also there are some biomarker response like the WBC count reduce and the procalcitonin, serial procalcitonin reduce. Then is the patient is improving. Okay. So now coming to the next variant, The patient was initially admitted in the ICU, maintaining 96% saturation for 2-liter oxygen, and routine blood investigation showing 14,000, hemoglobin in 10.6, 85% neutrophil, procalcitonin 0.32, and CRP is 17, AVG is 7.32, PaCO2 shifted to. Acha. So initially, actually, this is not ICU. Actually, patient was initially admitted in the HQ, but and this is the initial picture. And after that, patient deteriorate, and patient need more and more oxygen, and patient having high fever. So patient is hypoxic. So the patient has shifted to the ICU. So what will you do next?
Again, sir, airway, breathing, and circulation. I will take care of the patient's airway. I have intubated this patient. And then breathing, I will aim for, I will practice lung protective ventilation strategy in this patient, keeping low tidal volume, high respiratory rate, and plateau pressures below 30 centimeters of water. And
Just one thing I want to add. So when you will get the community acquired pneumonia patient, so if the scenario deteriorating, that means you are going to ARDS kind of scenario. If you have a long case variant, you always think about the next will come as the ARDS. So from the pneumonia, next will come as a ARDS. So in your exam, in EDIC 2 exam, you have to understand the pattern, be it CBS or be it CCS. If you understand the pattern, it will be very easy exam, and examiner will not go in depth because they want to know specific 3-4 answer. So pattern recognition is very important in EDIC 2. You are in correct. So what will you do next? So you will say that patient is hypoxic, hypoxia is increasing. So it might the showing that community acquired pneumonia is going worse, or patient developing which is going to be ARDS. So then whatever you have said, absolutely correct. So then so it is a ARDS. The patient is developing ARDS. They might give you that time another chest X-ray or the CT finding, which look like a ARDS, and then they will ask you, what do you mean by ARDS? What is the definition of ARDS?
Excuse me, sir.
Yeah.
I want to beg to disagree that this particular patient is deteriorating with maintaining oxygen saturation of 96 with only 2 liters.
Yeah, I understand. This is the scenario. It's when patient was in the ACE. So now patient shifted to ICU with intubation due to hypoxia, and the rest of the parameter I have not given. So suppose you think that patient shifted to ICU with a hypoxia needing oxygen, FiO2 is around 70% to maintain oxygenation around 92. So you imagine this is a case of ARDS. So you have to recognize the pattern. Okay. So all detail is not given here. So now come to ARDS scenario. So that time you might ask about the definition of the ARDS. So Priyanka, tell me the criteria for ARDS diagnosis. Yes.
So the respiratory distress should be acute in onset, that is less than 72 hours of the onset of the respiratory symptoms. And it should be bilateral infiltrates on chest X-ray, which could not be explained by effusion, collapse, or consolidation. And third is it should be hypoxemia, PF ratio less than 200 to 300, then it is mild, 100 to 200, then moderate, and less than 100 is severe. And also it should be non-cardiogenic. The cardiogenic cause of pulmonary edema should be excluded to classify as
So
ARDS.
when they will give you the ARDS like scenario, they will give you the particular the picture, the blood picture, AVG picture, and also the X-ray. So you have to utter that time that the X-ray showing that bilateral infiltration, the history is showing that within less than 7 days onset, and the AVG showing that PF ratio is less than that. So these are the thing matching the criteria of ARDS. And then you have to tell that these are the other criteria for the ARDS. The bilateral infiltration GGO is not due to the cardiogenic edema. Okay. Now, then tell me about the brief pathophysiology of the ARDS.
So in ARDS, there is diffuse fluffy infiltration of lungs with the alveolar exudates. And so there are three phases. First is the exudative phase, when there is infiltration of alveoli with all the exudates. And then it is followed by proliferative phase, when there is fibrosis of the alveoli. And then there is exudative, proliferative, then there is fibrotic phase.
Yeah.
Recovery phase.
Recovery phase, yeah, recovery phase.
So first phase where the alveolar capillary membrane gets leaked due to the accumulation of the inflammatory mediators like different cell, your neutrophil or NK cell, they causing the leakage of the membrane, and for due to the leakage there is a proteinaceous material come to the alveolus, and this material also attract more and more platelet aggregation, and this platelet also produce a lot of inflammatory mediators like interleukin and all. So then this is the inflammatory and exudative phase. After that, there is a proliferative and the recovery phase. So they want to know, but this one or two steps, and then they will ask about tell me about the ventilator strategy in the ARDS. So ventilator strategy.
Lung protective ventilation strategy. We try to keep the tidal volume 4 to 6 mils per kg of the predicted body weight. Predicted body weight is 45.5 plus 3.2 into 100 inches minus 60. And we can use 50 for males and 45.5 for females. And respiratory rate should be kept just to prevent hypercapnia in this patient. We can actually permit little bit of hypercapnia. Up to 50 to 60 millimeters of mercury can be permitted in this patient, and plateau pressure should be preferably kept below 30 centimeters of water. PEEP should be calculated as per the best compliance method of the patient to calculate the optimal PEEP and it should be individualized for every patient, and FiO2 should be kept to target saturation between 80 to 92%.
Very good. So it's an open lung strategy where the PEEP plateau should be less than 30, and we go for the ARDS net protocol, high PEEP and FiO2, depending upon how much FiO2 is required, and permissible hypercapnia to reduce the further lung injury. So that will be your ventilator strategy. And now tell me about the steroid in ARDS and what trial support this steroid in ARDS.
Sir, we can use steroids in ARDS, especially in severe variety of ARDS. The trial is CAPE COD trial, according to which we can actually use So steroids, they have anti-inflammatory effect and they can benefit by reducing the exudative phase in ARDS. So that is why they should be used in the early part within 7 days of onset of ARDS, and they should be given for a short course, preferably 5 to 7 days, and then we can simply discontinue. There's no need to taper steroids in ARDS. We can discontinue after a short course.
So one more thing I have missed, that open lung ventilation strategy. You always, I mean, you also utter that driving pressure should be less than 15. Okay, try to keep driving patient less than 15. So next, your question is regarding the lung recruitment strategy. What is your opinion regarding lung recruitment strategy?
Lung recruitment strategy. So lung recruitment is actually based on open lung concept, that we need to individualize PEEP for every patient, and we can select the optimal level of PEEP for every patient by using the best compliance method. The use of recruitment maneuvers where we use very high pressures for short period of time is not recommended by the American Thoracic Society for use in severe ARDS. So that is not recommended, but we can use the open lung concept, that is using PEEP.
It's very good. And also regarding the lung recruitment therapy, most of the trial has a negative impact. And the best thing is the follow the ARDS MED protocol. Now, what is your opinion regarding prone ventilation? So regarding the lung recruitment therapy, you can utter that we can go for the proning. Proning also improve the recruitment. So what is your opinion regarding the prone ventilation?
So prone position is beneficial in ARDS. There was a PROSEVA trial, which was a large multicentric trial, which showed more than half reduction in mortality when proning was done for more than 16 hours in patients with severe ARDS. So it is a useful strategy in cases of refractory hypoxemia. When PF ratio is below 150, we can use 16 hours of proning sessions, longer proning sessions, to improve hypoxemia. So basically, it causes redistribution of blood and kind of recruits the lungs. So helps.
If I ask you the three mechanism by which prone ventilation improve oxygenation, what are the three mechanisms?
So first is redistribution of the blood volume. So it kind of improves blood perfusion in the ventral part of the alveoli, which are better ventilated in ARDS. So also it causes homogenization of ventilation. The ventilation is also more homogeneous when we prone these patients, because the weight of heart is relieved in prone position, and the lungs are free to ventilate. Also, prone position improves the BQ mismatching of the uh, lungs by.
These two things, what you have said, that two things increase the VQ mismatch. And also because in the alveolus, what happened in the ARDS, there is a proteinaceous material that can drain. So improve the there are three lung structure, three area model in ARDS lungs. One is the consolidated portion where it will not recruit by your giving pressure and all, the PEEP and all. There are middle portion where the recruitable lung, where you, if you increase the PEEP, this lung will recruit and your oxygenation improve. And the upper portion is the your baby lungs. This is a normal lungs. So when you are doing proning, the three things happening. One is BQ mismatch is improving. How? It increases the surface area of the alveolus by recruiting the new alveolus, and also it reduces the compression pressure of the mediastinal structure like heart And third thing, you have rightly mentioned the homogeneous pattern of blood distribution, which increases the VQ, which reduces the shunting. Okay. So coming to the third variant, suppose the same patient, despite you are giving two prone ventilation, patient remain hypoxic and ABG showing that pH 7.26, PaCO2 52, PaO2 is 65, bicarbonate 18, lactate 5, and 100% FiO2 you are giving. So what will you do next?
So this is a refractory hypoxemia patient. Despite of giving two prone sessions, there is not much improvement in oxygenation in this patient.
Yeah.
So I will consider this patient for ECMO, extracorporeal membrane oxygenation, and I will give a call to the CTBS people and for the ECMO team to start the counseling and consultation process.
Don't say I will ask for the CTBS team. So, in exam, the examiner want that you know the ECMO. Okay. So I will call for ECMO. That's okay. Okay. Now the question is, what are the indication of ECMO?
PF ratio below 80 is considered
Below 80 for more than 6 hours. Below 50 for more than 3 hours. Okay. With all maximum conventional support. Okay. So what is Murare score? Murare score is another score for indication of ECMO. There are 4 parameters. One is the PF ratio. Second is the pattern of infiltration in the chest. How many quadrant is involved? 0 is the no GGO. 4 is the 4 quadrant involved. PF ratio also more than 300 is 0 score and less than 100 is the 4 score. And similarly, you have a chest X-ray, PF ratio. Then you have the fourth one, sorry.
PEEP and lung compliance.
Lung compliance is the last one, and a PEEP and lung compliance. PEEP is requiring 5 is the score is 0. More than 15 is 15 or more is 4. And the lung compliance is less than lung compliance is more than 80 is 0, and less than 20 is your 4. So if the score is 3 or more, this patient need ECMO. That is about Murare score. So now you tell me what type of ECMO you will, what modality of ECMO you will suggest for this patient.
So for this patient, I just want to improve hypoxemia. So I would like to place this on venovenous ECMO.
Okay. So modality is venovenous ECMO. So what are the type of ECMO you know?
So there could be venovenous ECMO, veno-arterial ECMO, or veno-arteriovenous VAV ECMO. So that all.
We will tell about 3 types. One is the venovenous, other is the veno-arterial, and third thing is the hybrid kind of thing. So it is depend upon the what organ needs support. If the only lungs is need support, then we can go for the venovenous. If the heart is need support, then veno-arterial. If both heart and lungs both is need, then arteriovenous. So hybrid modality has 2 types mainly. One is, suppose you are started with the venovenous and then there is a hypotension or the septic myocarditis or there is a ejection fraction is fall and hemodynamic support is needed, then venovenous you can convert it to the venovenous plus veno-arterial. Okay. Suppose you are giving, the patient is waiting for the lung transplant, you are giving the veno-arterial, and this patient having developed the pneumonia and going to ARDS. So you need to give the support of the oxygenation part also. Then veno-arterial plus you are putting the drainage cannula on the vein also. Okay. Now, if I ask you about the cannulation part of the ECMO, you just tell me how you cannulate your patient.
So we know venous, femoral vein, and jugular vein. We can cannulate both the veins.
The modality of the ECMO depending upon the what organ you are supporting and what type of cannulation you are doing. There are two cannula. One is the access cannula, the drainage access cannula, the drainage cannula, and other is the return cannula. So if you think, I will take separate classes on the ECMO. So drainage cannula, the drainage cannula usually we put in the grade phases like femoral vein where the blood come in the ECMO. So ECMO has three parts, major three parts. One is the cannulation. And in cannulation, the drainage cannula put it in the femoral vein where the blood come from the femoral vein to the your centrifugal pump. This from the centrifugal pump to blood goes to the your membrane oxygenator, and from membrane oxygenator it goes to the return cannula, and placing on the return cannula in veno-venous ECMO, you are putting the venous system like femoro-femoral. So one the drainage cannula on the femoral vein, the return cannula also in the femoral vein. Femoro-jugular, like drainage cannula in the femoral vein and the return cannula on the jugular vein. This is commonly for the veno-venous. And veno-arterial, we put the drainage cannula in the femoral vein and return cannula on the femoral artery. So femoro-femoral, or usually it is given in the inferior vena cava through the femoral artery, and sometime in the it's not very common use in the open lung surgery or in the cardiothoracic surgery. They can put in the aorta also, but usually the commonly practice we do veno-arterial is the femoro-femoral. And okay, that's things about the type of ECMO and gas exchange. Can you, anyone can, Priyanka, can you tell me how gas exchange happen?
Actually, the venous blood is a deoxygenated blood which comes via the drainage cannula, and then there is a membrane oxygenator which actually oxygenates the blood, and then that goes, and there's also a
How
sweeping.
the gas exchange principle happen in the veno-venous ECMO. So basically, the deoxygenated blood, the centrifugal pump, it rotates in the magnetic field. That's why it is a centrifugal. Nowadays use centrifugal pump. It has a very less effect on the hemolysis. It's a negligible hemolysis happen. Then when blood come into the membrane, that is called polymethyl pentane. This non-porous membrane, polymethyl pentane. It's a very small lumen inside of this membrane. Through this lumen, the blood passes, and outside of this membrane, there is a channel where the gas passes. Okay. So when the gas and the blood is moved the opposite direction, there is a by diffusion mechanism, the gas exchange happen. The oxygen enter in the system in the blood, and the carbon dioxide was out. So oxygenation depend on your DO2. DO2 is the blender gas where from the oxygen and the air is coming into your membrane oxygenator. So oxygenation depend upon your DO2, and the ventilation means what carbon dioxide was out is depend upon your sweep gas flow. Okay, so if your PaCO2 is high, you have to increase the sweep gas, and if your oxygenation PO2 is low, then you have to increase the DO2. Okay, so gas exchange principle, if they ask, you have to utter these things. And what do you mean by recirculation? It
So
is
when
very common in veno-venous ECMO, the recirculation.
So when the blood from the drainage cannula goes directly to the return cannula without going through the membrane and getting oxygenated, so that is called recirculation. And we try to keep
Recirculation happen when the drainage cannula and return cannula distance is very less than 10 centimeter. What happened? So oxygenated blood when enter the system in the superior vena cava, okay, and ideally the drainage cannula position, if it is a femorojugular, then your drainage cannula position should be just above the right atrium, and your return cannula, and your drainage cannula position should be less than the hepatic vein. Otherwise, there will be a mixing. So the oxygenated blood will again enter in the drainage cannula, and therefore the oxygenated blood will not circulate it in the system. So that is called recirculation. And if the recirculation happen, how will you understand recirculation happening? One is the color changes. So drainage cannula or blood is deoxygenated blood, always should be in blackish color, and the return cannula is the oxygenated blood, would be in the red, bright red color. If the drainage cannula blood is changing the color, become more and more brighter, then you understand that recirculation is happening. And also, if you check the PaO2 on the system and the arterial line, you will see that PaO2 will be lesser and compared to your PaO2 in the post membrane. So there should be gap, PaO2 gap should not be more than 10. If it is more than 10, then the gap should not be less than 10. If it is less than 10, the drainage cannula PO2 and the return cannula PO2, then there is a chance of recirculation. Now coming to what are the component of VV ECMO, already you have mentioned what is the cannulation and what anticoagulant you will use.
we can use heparin or bivalirudin also.
We are using the heparin. So what will be the dose?
80 units per kg bolus followed by 18 units per kg per hour, and we monitor the coagulation. Rotem we monitor.
Usually we don't do rotem. ACT we do at the bedside.
ACT.
Our target ACT will be not less than 140 and not more than 180 or 220. It should not be more than 220 or less than 140. So around we keep in around 180. So it's the optimal. 180 is the optimal ACT for ECMO. Suppose this patient develop bleeding or DIC. So what will you do? So to prevent clot, There is this two strategy. One is the anticoagulation therapy, and second is you can increase the RAM, increase the flow, where if you increase the flow, there is a less chance of developed clot. So when you are not able to give any anticoagulant, if there is a heat, you can change to direct 10A inhibitor for anticoagulation purpose, or you increase the RAM, so there is a less chance of clot formation. Okay. So winning criteria from VV ECMO.
When the patient when we reduce the ECMO flow to less than 50% of the previous value and the patient maintains good cardiac output, the peripheral perfusion is good, oxygenation is good, then we can consider weaning.
Oh, ideally, the weaning again, like a ventilator weaning, if the lungs is improved, so radiologically, and also what you have to do, you have to reduce the DaO2. DaO2 is the blender FiO2 actually. So you subsequently reduce your blender FiO2, and you check whether the patient maintaining saturation more than 92% with 50% FiO2 in the ventilator, and then your patient is ready for the weaning. Then you check the other parameter like lung compliance, requirement of PEEP, and if the lung compliance improve, and you can gradually decrease your DaO2, and you check the other parameter like pH, PaCO2, and the oxygen. When it is when the DaO2 is less is around 30%, and your patient maintaining the oxygenation and ventilation parameter, then this patient is ready for weaning from the ECMO. So ECMO is altogether one full class. I will take one ECMO classes. So, and ECMO troubleshooting is very important. So I will take classes on the ECMO, and I will discuss about details about the ECMOs, and both veno-venous and veno-arterial, and also the weaning criteria for veno-venous or veno-arterial is different. So I will take the full classes on that. So I'm stopping my sharing. So the actual exam will be like this. So what I have decided for my student who are appearing this November, I will take one CCS classes on Monday, and CVS classes on Saturday. So I want to start this CCS classes little early on the Monday, like 6 p.m. Is it okay for all of you? 6:30?
Yes, sir, fine.
Okay.
Okay.
So if you have any other question regarding this today's topic, you can ask me.
Any aspirants have any question they can bring up right now? Sir, I believe there is no questions at the moment. If any question arises, we'll be dropping in the WhatsApp group. Also, we'll be arranging a meeting too.
Yeah. So Subhendudar, so next what I will do in this Saturday, we'll take classes on ECMO in details, and second I will take classes on CVS. So in this CVS, I will take images, and 5 images, 5 curves, and 5 lab values. Okay.
Sure, sir.
Okay, thank you.
Thank you, all the aspirants. We'll be keeping you notified for the next classes. Thank you all. Thank you, sir.
Thank you.